Welcome to the Jerry Pal Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome back Chris Jones, who's a geriatrician and palliative care doc. And get this, for today's podcast, a certified professional coder. Chris is clinical vice chief for outpatient palliative care at Duke. Chris, welcome back to the Jerry Pal Podcast.
Thank you.
And we're delighted to welcome Phil Rodgers, who's a palliative care doctor and family medicine doctor, and is the George A. Dean Professor and Chair of Family Medicine at my alma mater, the University of Michigan. Go Blue! Phil, welcome to Jerry Pal.
Happy to be here. Thanks for having us.
And me.
Oh yeah. That's terrible. It's like, wait.
That was like a blooper.
And we're delighted to welcome back Lynn Flint, who's a frequent guest and host on this podcast, today serving as a guest host. And Lynn Flint is a palliative care doctor from the office next door. Lynn, welcome back.
Thank you very much.
So we're going to be talking about medical billing and coding, the subject everybody wants to listen to on a podcast. But I've actually seen Chris and Phil talk about this. They make this actually really exciting, and we'll talk about why it's important for everybody to know at least some components of billing and coding. Before we get into that topic, who has the song request for Alex?
I think that's me today.
Chris, what is the song request?
We really thought through what would be a valuable song request around billing, and it has to be If I Had $1 Million.
Great choice. Here's a little bit. If I had $1 million, if I had $1 million, why buy you a fur coat, but not a real fur coat? That's cruel. If I had $1 million, if I had $1 million, why buy you an exotic pet like a llama or an emu? If I had $1 million, if I had $1 million, why buy you John Merrick's remains, all them crazy elephant bones? If I had $1 million, I'd buy your love. If I had $1 million, we wouldn't have to walk to the store. If I had $1 million, we'd take a limousine 'cause it costs more. If I had $1 million, I'd be rich.
Llama or llama?
I had the same question.
I don't know.
We're just hoping you can get a chaplain or a social worker with that $1 million.
Exactly
Yeah.
right. Maybe a massage therapist. You don't have to have a donor fund.
Well, let's talk about that, because you know what? We're talking about billing and coding and the importance of billing coding when we think about palliative care teams. But damn it, Phil, like, I am a doctor. I need to be doctoring. I'm not a slave to the C-suite. Do I really have to, and does my team need to really know about billing and coding?
That's an excellent question. And you know, there's a few things, having done this a while, that we find are important to make sure we say. And one of them is actually a line of Chris's that I'm going to share with you, which is that palliative medicine pays for palliative care. And what I mean by that is that the primary people who are going to be coding on your team are the physicians and the advanced practice professionals, right? Your NPs, your PAs, your docs. Residents can bill under appropriate supervision, so can fellows. With few exceptions, the other extremely valuable members of your interprofessional team, your social worker, your nurse, your spiritual care provider, in some cases, your psychologist, if you're so lucky, most of the time cannot bill in a lot of the settings where we work. So ensuring that you optimize revenue for your services enables you to have the resources to support your interprofessional team. Did I get that right, Chris?
Yeah, when we talk about this with folks around the country, what I'll often encourage, because you have to get people, you have to hook them when you're trying to teach this stuff, And why does it matter? It matters because if you can get a bit more revenue, you can turn that into a social worker, you can turn that into a chaplain. So the work that you're already doing as a provider, if you can turn that into a bit more money, it's going to be more help for your patients. So this is not feeding some stock plan somewhere. This really does turn into the care part of palliative care.
And just to clarify, the folks who can bill, it sounds like, are the MDs and advanced practice nurses.
And physician assistants, right? So we use the term advanced practice professional to cover NPs, PAs, also CRNAs are in there and other folks, but on palliative care teams, it's NPs and PAs.
All right.
And on the outpatient side, I'll just add, if you have a social worker who's doing therapy, that's a billable service. If you've got a psychologist in the clinic, that's a billable service. But if you think about the breadth of true palliative care, if you've got a full IDT, there are not a lot of the members of the IDT who can submit those bills to Medicare.
Okay.
Yeah.
All right. So my other question, and me and Lynn had a chance to review your CAPSI slides and stuff, and I went to your last talk at AHPM. It was fabulous. We'll have links to that on our show notes for everybody. But I remember one of your slides, which was really helpful for me, is like, how does this billing stuff work? And there's all this like alphabet soup of words as we think about the billing process. Can you just real quick for our listeners, how does billing work in the steps that you've outlined?
Yeah. So real quick is going to be the goal, and that's what I'll shoot for. So you see a patient, you prepare to write a note. What you have to do is somehow talk to or communicate with the payer what you did, right? So there are two kind of alphabet soupy buckets. The first are the diagnoses you treated. Those are called ICD-10 diagnoses, International Classification of Disease. And that's things like dyspnea or COPD or non-small cell lung cancer. And those now ICD-10 has the numbers and the letters. So depending on what you treated, you pick a few ICD-10 codes. Then you think about either how long you spent taking care of the patient or how complex the visit was. And you turn that into a billing code, what's called a CPT code, or common procedural terminology. That's the 5-digit code. If you run in the hospital, that's 99233, for example. And 99233, that billing code counts as a high level or high complexity hospital visit. And that turns into money. So the way that I think about it is, you see the patient, as you're writing your note, you think about your diagnoses, ICD-10, you figure out what level or what the complexity of your visit was, that turns into a CPT code, and then that CPT code goes into the payer, and then your institution will have a contract with the payer that turns that into a certain amount of money.
And this is all true if I'm doing geriatric consults, palliative care consults in the hospital, kind of the process is the same, and it's a similar process in the outpatient setting. Is that right?
Yeah, absolutely.
Yes. There's only one set of CPT codes that any clinician can use to describe the service that they deliver. One of those other alphabet soup phrases are E&M codes. You might have seen that, or E/N, and that stands for evaluation and management. Those are the most commonly billed codes in CPT. All specialties use the same code. So in the outpatient setting, that's 99202 through 99205 for new patients, and 99212 and 99215 for return patients.
Okay.
Whether you're a palliative care, a geriatrician, or a cardiologist, you use those same two codes to describe the work you do in that setting.
E&M is a part of CPT.
Correct. They are a subset of CPT codes, and they are a minority. Here's where those of us who do non-procedural work have it a lot easier than our proceduralist colleagues. There are over 10,000 CPT codes. There are probably about 30 of those in the E&M space, maybe 50 if you count the emergency department codes. Yeah. Everything else are very, very detailed procedural codes. whether or not you remove the stone from the proximal, middle, or the distal ureter, right? There's a lot of that complexity. We don't have to worry about most of that. I will say, and we'll probably get into this, the advanced care planning codes, which are celebrating their 10th anniversary this year, are also considered evaluation and management codes. So they're under that E&M umbrella.
So let me ask you one other question, because ICD-10 always confuses me. So ICD-10 are the diagnoses, right?
Yep.
How important is it to be as specific as possible with those ICD-10 codes? So let's say Lynn comes to me as a patient. She has a wound in her leg. Should I put it as a wound in her leg? Or if I find out that she was bitten by an orca, whether or not I should use, there is an ICD-10
code for that.
For shark bite.
Orca. Subsequent encounter, yeah.
How important is it to be that specific, or can we just pick and choosy kind of our ICD-10-ish?
I don't feel strongly about this. I usually pick the unspecified code because it's fewer clicks for me. And I just lost my certified professional coder standing by saying that. You're supposed to go out to the 7th digit, left, right, up, down, thumb, forefinger.
What type of orca was it? Right. Yeah.
Right.
Over 8.
Northern Pacific.
Exactly.
I have a question.
Yeah.
Oh, sorry. Quick question. When you think about
one more just nuance to that, if I could, and I'm going to take off my clinician hat on because Chris is right. As long as you put a code in for the CPT, the payment is the same. I'm going to put an institutional hat on, though, for a second and say that actually the only way that we can describe how complex the patients you are seeing is in the ICD-10 codes and in your documentation. That really matters. We're talking a lot about fee-for-service Medicare today and commercial payers. In the Medicare Advantage world, which is now in my market, 60+% of the patients, having an accurate depiction of how complex our patients are actually makes a difference. So I will get off I will take my chair hat off for a second, but it does matter institutionally.
Well, that relates to my question, actually, because you talked about the beginning of the life cycle of a bill. So the provider puts all that info in, and then it goes off somewhere, and some person reads those codes. And is there somebody who in certain institutions might be tweaking them to reflect complexity? What does that look like on the other side?
So a lot of this on the hospital side, they will tweak complexity because the more complex the patient looks, the more they're going to get paid by the payer. Mm-hmm. On the outpatient side, the complexity is more at the level of the code, not at the level of the patient. So did I do a high level visit, a moderate level visit, a low level visit? It's never a low level visit in palliative care.
Right.
What I always say is I am a level 4 patient when I go see my PCP. I have 2 chronic conditions, asthma from cats, and I'm a little fat, so I have GERD. And they refill my albuterol. That's a level 4 visit. So if you as a palliative care doctor are seeing somebody weller than me, then they could be a level 3, but you're doing your clinic all wrong. So in the hospital, they try to build on the complexity of the patient because that does depend on how the hospital gets paid. But in the clinic, it really is the complexity of the visit rather than the complexity of the patient.
Okay, got it.
Okay, I got another question. Actually, should we go to another question? Or should I just read our first case?
Let's get into the cases.
Let's go to the case because I want to talk about this question about time versus complexity coding.
It's our favorite.
Which should I use?
It's our favorite.
But I'm going to start off with the case just to get this a little bit clinical. So we got a new consult. It's a 73-year-old with metastatic pancreatic cancer in the hospital who Palliative Care was consulted on for goals of care. The fellow sees the patient, spends 60 minutes with them talking about goals of care, their cats, their asthma, and their GERD. Afternoon, the team meets with the fellow to discuss the case for 45 minutes together. I do some really amazing goals of care teaching with them. We talk about our cats.
You show pictures of your kid.
Yeah. And then the attending, the fellow, the pharmacist, and the social worker all come together and we walk to the patient's room. We review kind of what was discussed with goals of care for 15 minutes with the patient. We leave and we plan for a family meeting the next day. No new changes to meds. So I'm trying to think about the process of billing. So you said the first step is I've done my clinical encounter, right? What do I do next with this?
Phil, do you want to drive this bus?
So a couple of clarifying questions that we'll hand it off to Chris because he's got a special power here. Did I hear you say that the fellow spent 60 minutes in the room alone?
Yes.
Before they came out and sat.
And then we talked about it. We reviewed it with the team. We talked about it amongst ourselves. No other cardiology, oncology, nobody else was involved. Then we go back, we talk with the patient 15 minutes, and we agree that we need a bigger family meeting.
Okay.
And then we leave.
And no symptom assessment, no symptom management.
The fellow did all that, but when they talked to us, we're all, we're not going to focus on symptoms. It seems really well controlled. They're not having any symptoms. So we just focused on, next step that we're going to do as a team is a palliative care family meeting with a patient and maybe oncology.
Okay. A couple of things. One, fellows cannot bill on time. Just hear that. Only attending physicians and credentialed advanced practice professionals fellows cannot bill on time. So their time doesn't count. Fellows can bill on complexity. So I'm going to assume that this fellow did your standard new patient consult on a palliative care patient who's got all the things.
Yep.
And did they reflected the complexity of the care that's being delivered, and not just the goals of care, but everything else.
Yeah.
And then if I got the kind of sequence right, you spent 15 minutes in the room with the patient. Yep. How much time did you personally spend outside the room talking about the patient's care with either your team or the consulting team?
Does that include teaching about the patient's issues? Like
this is
goals of care discussion, like talk and education for half an hour. The rest of the time we spent 15 minutes in particular talking about this patient's case, but half an hour talking about goals of care, how to have these family meetings.
If my compliance people are listening, you cannot count teaching time. That is a lot. Now, where does teaching and clinical care, where does that, that kind of charcoal gray area sit? I will leave that up to your high ethical judgment, but it truly is your time. Now, what is now different that I will point out? So we did a big overhaul of E&M starting in the outpatient setting in 2021 and then all settings in 2023. Pre-2021, you could only count your time, the attending physician time, in the room with the patient face-to-face. What is now the case is time in any setting, outpatient, inpatient, can count total time on day of service, whether in the presence of the patient or not. That can include everything that is record review time, that is, talking to the consulting team to actually get their concern time. That's what I like to call crazy uncle time, right? Like the time that you're on the phone with the family member who just needs a lot of you. So you can count all of that up. That counts. Strict teaching time gets carved out of that. So I think, and Chris, this is where I'll hand it off to you. What it'll come down to is what are all those minutes versus the note that your fellow writes to reflect what they did about the complexity of that. And then you need to add it up and decide which is which.
What are ways to document complexity? Like what kinds of words document complexity?
So this one,
Dr. Jones.
Yeah, I think back, Charles Von Gutten has been a mentor of mine for years. And what Charles says is, whenever you're a question like that, or if you're fighting with your coders, you have to return to the sacred texts. And the sacred text that answers your question is called the CPT book, that common procedural terminology.
Yeah, I got that right here.
Mm-hmm.
Well, so here's the thing. I do have a copy of it because I have to, but your coders have a copy. And this is where, when we teach 350 people at AHPM and then they go back and said, but Jones said X, Y, and Z. No, your coder does not care about me. What you have to say is, can we look at the CPT book together and interpret it together? So there's a table in the first part of the CPT book. In the 2025 version, it's somewhere between page 10 and 15, where there's a chart that looks at the diagnosis, the data, and the complexity of the risk of the patient. And there are words like severe exacerbation of cancer pain, severe progression of ILD, I personally interpreted an EKG. I discussed management of the patient with Dr. Smith from cardiology. The decision was made for a DNR today. All of those sorts of words are the high complexity things that we do in palliative care.
What did you say those three components? The diagnosis?
Diagnosis, data, and risk are the three columns. And if you if you get a copy of the CPT book and you look at the high level component, if you meet criteria in two of those three columns, so you don't need all three, then you have a high level note. So I'll estimate when I do inpatient palliative care, I would estimate 90 to 95% of my initial consults are high level. We do a ton of cancer pain management here. We do a ton of advancing dyspnea from COPD and ILD and heart failure. Those things are all high complexity if you write the right words.
Because so you have bad diagnoses, complex diagnoses, and because you're changing around like pain medicines.
IV opioids particularly. If you have a decision regarding an IV opioid and you have a severe exacerbation of a thing, those two things, just those two things together, make it a high-level note that day.
Yeah.
Even if it took you 10 minutes with your expertise.
Yes.
So this is an opening for one of the other things that we want to make sure that we say, and we say this often enough in all of our presentations. Just because something complex and valuable is easy for you to do as an experienced and trained palliative care clinician, like IV opioid dosing, like high-dose opioid rotation, like concomitantly managing benzos and opioids, right? Things that are in our wheelhouse. Just because they don't feel hard to you doesn't mean they're not complex and they're not valuable. I can speak from my experience as both a primary care and a palliative care doctor. We have kind of professionalized low self-esteem just because we tend to get paid less than everyone else, right? So we just walk around saying, well, maybe they'll let me in the room today. No, like you walk in there, they've asked you to come. People don't call you unless the patient is sick. Like by definition, as palliative care clinicians, something serious is happening. So that gets you in the door. And then you're doing really important, complicated, high-risk things, and you're doing it at a very high level. And as you get good at it, you process it very quickly and easily. So it doesn't feel like a heavy lift for you, but it sure as heck was a heavy lift for the referring team. That's why they called you. So kind of own your expertise, know your value, and bill for it.
Great.
I'll ask a question.
Yeah.
Lynn has many educator roles as well, including being director of our Jerry Pal Fellowship. Lynn, do you teach this to the fellows? And then we could turn to our guests and see to what extent they teach billing and coding.
Great question. We do teach this to our Jerry Fellows and Palliative Care Fellows in a didactic way, also in clinic. I have to make sure I'm teaching them everything correctly. And I would say I often say those words that you are seeing the most complex people. So you're pretty much always going to be a very high level visit. And I also I can think of a visit yesterday where I did an opioid titration for somebody. It was really easy for me. And I thought, that didn't really take me that long. And I probably coded it lower than I should have.
I'm not going to pick on surgeons, but they get paid the same whether the appendectomy is easy or hard.
Right. That's a good way to put it. Yeah.
It's like that. And that's not their fault. That's the system we have. I mean, we should all start by invoking Barack Obama, who back when the ACA was out said no one would build our system if they were starting from scratch, right? This thing makes no sense in any way. But knowing this system we have and understanding how we can survive and even borderline thrive in this, I think is a responsibility we all have together.
So it sounds like that's part of the reason why we should probably learn more about complexity-based coding versus time-based coding. So for example, this case on the inpatient side, I only saw them for 15 minutes. I didn't spend a whole lot of time reviewing the CPRS, maybe 10 more minutes on top of that. So 25 minutes total. And then the fellow is then contacting the other team members to organize the family meeting. So spent 25 minutes with the patient, with my documentation, co-signing. So it would be pretty low level of time. But if it was based on complexity, I actually may be able to bill at a much higher rate. Does that sound
you
right?
actually have two things there, because the case that you gave us, because the fellow did some symptom assessment, even if it's continue the MS Contin, continue the oxycodone, that is some symptom assessment. They're managing the pain, they're managing the dyspnea, the constipation that nobody manages. I once had a patient say, "You're the best doctor I ever had." I said, "Why do you say that? You're 92, you've seen so many." She goes, "You ask about the bowels every time," right? Like that's something we can bring to the clinical encounter. So if you do some symptom work, even if you're not reinventing the wheel, and then you spend some time on goals, values, and preferences. Eric, you mentioned 15 minutes for your advanced care planning. Mm-hmm. I might encourage you to spend 16 minutes, because at 15 minutes, you're a member of the Medicare Volunteer Corps. At 16 minutes, you trigger 99497, which is the first advanced care planning code. But yeah, you can go in the room one time and leave with 2 codes if you do symptom assessment and management and also do advanced care planning for 16 minutes or more.
Okay.
Yeah. And one other small nugget about that particular case, Eric, time-based billing is even harder for initial encounters because the time thresholds are higher for the initial encounters than they are for the subsequent encounters. It takes more time to get to the higher level. Yeah. So I'm going to guess that you would do better. You're probably getting a 99204 at least, and maybe an 05 out of your fellows work. You probably can only get a 992, Chris, what, at 25 minutes.
Well, these are probably inpatient. This is inpatient, Eric, or outpatient?
Inpatient. We're going to move to outpatient.
Sorry.
Yeah.
So the inpatient times are 75 minutes for the high level, 55 minutes for the moderate level, and then I think it's 35 minutes for the low level. So
real quick for our listeners, what counts? What things can I look at as far as judging my time? So face-to-face with the patient.
So I got you. Yep. It's everything except for travel time and teaching in the generic. Okay. So looking through the chart, getting history from the nurse, talking to the patient, examining the patient, getting collateral, writing your note, writing your orders, looking at the EKG, teaching your team about hyponatremia when they have hyponatremia in the context of that individual patient's care. All of that stuff is billable toward time. But remember, if you're going to bill advanced care planning, you don't want to bill your symptom work on time. You want to bill it on complexity. That's a bit of a nuance that's best practice.
And is that true also in the outpatient setting as far as all the things you mentioned that counts for time?
Yep. The only thing in the outpatient setting, the home care teams get killed on this. The windshield time, you're a volunteer. Okay. But everything else, it used to be you'd have to write your note in the house, even if the house was itchy. But now you can go in your car and write the note, because anytime you're doing time-based service, it's all time on day of service. So it's not unit and floor time. It's not in the house time. It's all time on day of service.
Okay. Should we move our patient to the outpatient world?
Mm-hmm. Yeah.
Okay. Yeah. So the same patient gets out of the hospital. They're referred to the outpatient clinic for palliative care. The nurse for the clinic calls him a week ahead, does a nursing assessment for 45 minutes, talks with the caregiver, and then gets the patient an appointment in clinic. On the day of that appointment, on the consult, the patient sees the MD and the RN. Since the hospitalization, he's now developed poor appetite, abdominal pain, and the MD and RN spend 60 minutes face-to-face. They do rapport building, they evaluate symptoms, they order opioids, and then they review the advanced care planning that was done in the hospital. Then they finish the visit. The doc then sends a Teams message to the oncologist to let them know what they did. And then a few days later, the nurse follows up to check in with the caregiver and see how the symptom management plan went. And then a couple of days after that, the palliative care pharmacist calls and checks in about the meds, provides more education. What do we do there?
I love this care. I'm going to make you so sad. So there's so many bad things I'm about to tell you.
Oh, no.
The first bad thing is because they were seen by your inpatient team. If it's the same practice group, same subspecialty, they are not a new patient in clinic. They are an established patient in clinic.
Really?
Yeah. So in clinic, you get zapped with the follow-up codes, essentially, the established codes.
Wait, can I ask you the other
Oh.
way? If outpatient was seeing them and then we see him on the inpatient side, is that a new patient?
So yes, so this is the interesting thing, is on the inpatient side, hospital, GIP hospice, and SNF. Each time you get admitted to an inpatient setting, the first time a specialty sees you, you get an initial visit. But the way new patient is defined in the clinic as is they've never been seen by anybody, same specialty, same subspecialty in the practice group in 3 years.
Whoa.
So if someone, if your partner
What's
saw them-
considered a practice group? Can I just shunt Lynn off to a different practice
So
group?
it depends. There are some practices like my group here, our inpatient and outpatient and hospice are all the same practice group. So if somebody saw the patient 2 years and 11 months ago in the hospital, and then they come in on fire to me in clinic, they're an established patient.
Oh.
I know.
I think if it's, I know. I think it's the same, especially under the same tax ID number in the same enrollment group. I mean, that's the back end of this, but it's truly unfortunate. So, Chris, in what other ways are you going to disappoint our colleagues?
Yeah, so the other way to disappoint,
Breaking my heart.
RN time is critical palliative care, but it's not reimbursable. If you saw the patient in clinic and created a principal care management program or a chronic care management program and you enrolled them in that, then your nurse or your social worker time would be payable. But this is what palliative care is. Please don't no-show our appointment because we're giving you a lot of time.
Yeah.
That nursing call is free. We actually have that done by our volunteers at Duke because they wanted to be helpful, and it's an unbillable service. Your pharmacist also, telephone calls by pharmacists are not billable. Phone calls by nurses when people are outside of principal care management, chronic care management, or principal illness navigation, all of that is non-billable. And that's the thing we said at the beginning of all this is palliative medicine has to pay for palliative care because all of these other people who do such a sometimes more important job than I do when I'm fiddling with a methadone prescription, and they're the ones dealing with the anticipatory grief about dying as a 30-year-old with 2 kids. I don't know how to do that. I'm not good at that.
So when Lynn is deciding,
when they're not.
When Lynn is deciding to choose the lower level, because she said, oh, that didn't take a lot of time or complexity, I'm just going to choose that, versus the higher one, she should be thinking, this is for my team here. This is so I continue to support the pharmacist, the social worker.
Exactly right. And the other nuance about outpatient care, is if we just now cone in on your time, Lynn, you can only count the time on the calendar day of the appointment.
Right.
So, midnight to 11:59. So if, for example, you know that there's a complex patient coming in Tuesday and Monday afternoon, you do the deep dive on the chart, that's volunteer time, unfortunately. So it truly is just total time on the calendar day of service. On the inpatient side, because of the nature of how we do it, we tend to do each day's work on that day. But you and all know how outpatient work can go. It can bleed over, and so just know it's calendar day only in the outpatient setting if you're tracking time.
Question about time. So if you want to bill for time, using time, you're going to document the time that you spent in the visit. If you want to bill on complexity, how do you document that if you have a system that has kind of a free-form note and then in a separate encounter form? Do you do anything in your note?
I have so many thoughts on this. Yes.
All right.
So if you're billing on time, you need a time statement. And the generic time statement is, and I'm going to speak in Epic, so I'll say ****. I spent **** minutes providing care to this patient on the calendar day or on the day of service, face-to-face and non-face-to-face, period. Separately billed, procedures not included, or something like that, to just push out like if you're doing a hip injection or something. Your other question, which I just forgot, if you're going to bill it on complexity. So technically what they teach the coders is it's the 4 corners of the note. The problem is a note in Epic prints out on average at 8.5 pages long. And the average coder has 4 minutes to code a note. So they can't read the whole thing. It's just impossible. So when Phil and I teach this around the country, what we teach is we teach a billing smart phrase. So I actually have what we call our medical decision-making smart phrase, where you are picking the pieces from that complexity table in the CPT. What did I do today? You're putting them in one spot at the bottom of the note. So when the coder or the auditor looks at the note, they always go to the bottom first because they're looking for the time statement. And then whether they find the time statement or all these complexity words, they know what you're intending.
And the complexity words, do they refer to those three things: the diagnosis, the data, and the risk?
Yeah, what I always encourage is that you as a clinician, if you can learn the words, or if you have a medical decision-making pick list, what you want to do, you want to create for the auditor the most boring search a word in the whole world. You want them to find the words they're looking for. Severe exacerbation, decision regarding DNR. Because what you don't want a coder to have to do is interpret or intuit anything. Their job is to translate the note into a code. So if you give them the words that are in their rubric, then they're going to know what you intend. Where if you just say, bad CHF on a bunch of oxygen has an AKI, they're going to go, is that a severe exacerbation? I don't know. Where if you say severe exacerbation of CHF with an AKI and 6 liters nasal cannula, then they know, okay, that's high level in the diagnosis column.
Yeah, and just the other thing to underline, which I think has gotten a little bit internalized, which is great since the rule changes in 2021, if you're billing on complexity, the only thing that matters is the medical decision-making section. You may remember, Eric and Alex are probably practicing years ago, where the 12 points on the review of system and the family social history, and then the
physical exam, you got to meet all those.
All of it's gone.
Do I even have to document that stuff anymore?
Well, so the HPI and the physical exam is for your colleagues and your lawyers, right? Like, you want your colleagues to know what you did as good clinical care, and you do want to make sure that you accurately reflect what happened, but you no longer have to go point by point by point by point. Like that old review of the systems negative times 14 should be expunged. Now, our notes have not caught up. Like our notes, I think it's going to take a generation for our notes to improve, but ideally the notes can be tighter, smaller. But as Chris said, sort of, if you can get to that language and get in the habit of using it, it actually makes things easier on you because you get more stock language. I don't think we'll ever get to templated palliative care notes because we want to tell our patient story, but we can get, I think, to more efficient documentation that accurately reflects the complexity of care that we have and then serves your billing purposes.
So to be really, really granular, to reflect complexity in you do not talk about time in the note, no time statement. And you have an assessment and plan that contains these buzz phrases like severe exacerbation. We made a decision about a code status, those kinds of words. We titrated an opioid.
As long as it's parenteral. And you have decision regarding parenteral controlled substance.
So the word
risk.
Decision is important. Got it.
Yep. Yeah, if you can reach out to your coder and say, hey, can you send me the complexity table from the front of the CPT book? Number one, they'll think you were dropped from outer space because clinicians never ask them for that stuff. And you will realize all the answers were there the whole time. They were just never taught to you in a way that you were able to internalize. That's kind of what Phil and I try to do, is say, hey, there's a book. Then on half of a page, it tells you what the answers are to billing. You've just never bought the book because it's $138. Your coder will copy that page for you.
Is that page on the internet, or do we have to get that book?
You should reach out to your coder so that they know that you care about this stuff.
Okay, wait. We don't have that much time left. I think we need to spend a few minutes on advanced care planning codes.
Yeah, we do.
Sure.
Yeah.
Okay.
Of course.
So should we do sort of quick hits
Lightning
questions?
rounds.
Okay. So first advanced care planning code, we learned you need to talk at least 16 minutes. How do you document in your note to indicate to match up with that code?
Yeah. So there is actually no language in any of the code that proscribes this. CMS has provided us some guidance, right? You should, in general, to document who is present in the discussion, because you can have the discussion with the patient or with their surrogate if the patient is not able to participate. In the early days, there was all this question of like, do you have to be in the room? Can you be outside? Can you be in the ICU lounge? Do you have to see the patient from here? Right. So, but in general, you need to be in the same side of service. You should broadly discuss what you shared with the patient and any decisions that are made. Specifically, you don't have to make any decisions, right? You could say, we're going to continue care and revisit. You do not have to complete an advance directive, but you should document it if they were discussed. If you're going to try to identify a legal decision maker, a patient advocate in our state. So best practice, who was there? What did you talk about, and what was the outcome of that, even if it is simply to continue current plan and revisit?
And then you can add that to your complexity code.
Yes. If you build on complexity, you can then also build the advanced care planning code. That's the Chris Jones, go in for one service, come out with 2 codes, right? Now, best practice is to write a separate advanced care planning note, right? That is best practice, to write a second separate note. If you're going to include it in your note, segregate it out very clearly from all of your other E&M documentation. Put it as an advanced care planning addendum, something like that. There's actually an advanced, I'm going to speak Epic for a second, because Epic's, of course, the Walmart of health records outside the VA. They actually have an advanced care planning note type, which will flag and you can search. We use that because that's where our colleagues go to see our work, and it's super valuable when they're trying to figure out what's going on.
Okay, another lightning question. Social determinants of health assessment. Is that a code? Is that I hear that was a code?
Yeah, that's a code in the clinic. It has to be an assessment. It isn't just a survey. So you can't just have them fill something out on paper and then it not be addressed with the clinician. If you find a social determinants need, you have to have a referral process in place. So you can't just write, oh, yeah, they don't have any food, and then move on with your day. And it is a code. It's about a 5-minute code. It doesn't pay very well. It's about $8, $8 or $12.
Yeah, it is not a lot of money.
Okay. And then another lightning round. When somebody goes on to hospice, but let's say I'm an outpatient palliative care doc, I'm maybe their geriatrician, and I keep in touch with the patient, and I'm doing some visits, can I still bill for those visits even though they've now gone on to hospice?
This one stresses me out.
Yeah. So this is where I'll step in because I don't mind. As long as you do not have a financial relationship with the hospice, right? As long as you're not a hospice physician, that you're not employed by them, you're not on contract. If you're truly, serving as this patient's geriatrician, you can sign up to be their kind of hospice doctor as long as you don't take anything of value from the hospice itself. If you're employed by the hospice, you cannot separately bill Part B because you are to be paid under the hospice per diem.
All right, my last lightning round question, because we couldn't cover everything. There's so much more to learn about this. I understand that this is important. Where can I learn more?
Yeah, so there's a couple of things you can pull down from online. CAPC has really leaned into this, and Phil and I have helped them along with Andy Esch and Bryn and her team.
We'll have a link to that on our show notes. We'll have a link.
Yep, CAPC. And then there's 2 other things. We did back in 2016 when the ACP codes came out. There's a top 10 article about advanced care planning that's open access.
Great. We'll link to that too.
Yep. And then the CPT book, you want to get the copy of the CPT book, those couple pages. And then the last thing about advanced care planning, the Medicare Learning Network has offered back in February or March of 25 some documentation guidelines and best practices around writing up your advanced care planning documentation. So Medicare Learning Network, advanced care planning, if you Google those words, you'll get a 7 or 8 page PDF from the government.
Great.
Yeah, and the last thing I'll say, because Chris won't, every time he says Phil and I, what he really means is Chris Jones. So Chris is the brains behind the operation. He's the Al Michaels, whatever Chris Collinsworth through. I just do color. Chris does fabulous consulting on this. So, he will not self-promote, but I will promote him. If you have the interest in your organization, I would make the very strong case to have Chris Jones work with your team. He could do it virtually. He'll do it on site if you're in the right place at the right time of year.
All right.
But that's high value.
Chris,
it'll
is
pay
it
for
okay if
itself.
we have
multiple
a
times.
link to you on our show notes as well? Just
Yeah,
in
that'd
case
be great.
people- Wonderful.
Yeah, that'd be great.
And then if
Yeah,
you want a part two of this, we're happy to break.
And then
This stuff is so important. And the thing is, it's complicated, but it's not hard. If you can manage hyponatremia, this is way easier than hyponatremia because you don't have to figure out if they're wet or dry.
I love this. I am convinced that this is going to make me $1 million. My last question is, Alex, what are you going to do with $1 million that we've just earned?
If I had $1 million, if I had $1 million, well, I'd buy you a monkey. Haven't you always wanted a monkey? If I had $1 million, I'd buy your love. If I had $1 million, 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 I'd be rich.
I get a chaplain, a pharmacist. Chris, Phil, thank you for joining on this podcast.
Our pleasure.
Thank you. Thanks so much.
That was
And
fun.
Lynn, thanks for being our guest host.
No problem.
And thank you to all of our listeners for your continued support. We'd also like to say a big thank you to those who've donated more than $250 to the Jerry Pal podcast over the last year, including
Anna Lynch, Deborah and Jeffrey Larson, Krista Mossack, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Samoji, Matthew Schuster, Carrie Hagan, and Lloyd Woolstat.
a very big thank you. And if you too want to donate to the Cherry Pal podcast, please go to the Cherry Pal website and click on the blue or orange donate button.